Hi everyone, welcome to our module on glycogen. Glycogen is the storage form of glucose. When there is excess glucose available, the cells of the body can convert it to glycogen and store it for later use. Glycogen is a polysaccharide. It is a polymer made up of repeating units of glucose, and it's most abundant in the muscle, as represented by this muscle-bound man here, and the liver, and that's why I've shown you a picture of the liver on the screen here. Now, the muscle can break down glycogen for its own use, but the muscles cannot release the glucose that comes from glycogen into the circulation to be used by the tissues. The liver, on the other hand, will store glycogen, and when the liver breaks it down into glucose, it can actually release that glucose into the bloodstream so that other cells can use it for their own purposes. This is a picture of the molecular structure of glycogen, and you can see that it is a long chain made up of repeating units, and these repeating units are glucose molecules. If you look at this picture on the right side of the screen, you'll see that there are two different ways that the glucose molecules can be linked together. They can be linked together in straight lines, like what I'm circling with my pen right here. And this is a linkage between the one carbon right here of one glucose molecule and the four carbon right here of another glucose molecule. So therefore, this is called a 1,4 linkage of glycogen. The other way that glycogen can be linked is by the 6 carbon right here and the 1 carbon of another sugar, and this is called a 1,6 linkage. And these 1,6 linkages make the glycogen branched, and that's why you see in this picture down here on the bottom of the screen long chains of 1,4 linkages, and then occasionally you see a branch into a 1,6 linkage. And the reason glycogen is branched is because this makes it more soluble and it makes it possible for the body to store more of it inside of cells. Glycogen synthesis is an offshoot of glycolysis. Recall that the first step of glycolysis is conversion of glucose into glucose 6-phosphate by the enzyme hexokinase or glucokinase, depending on which tissue of the body you're talking about. From glucose 6-phosphate, the molecules can progress and go through glycolysis. However, they can also decide to head towards glycogen synthesis as an offshoot of the glucose 6-phosphate stage of glycolysis. Cells in the body use a four-step process to convert glucose 6-phosphate into glycogen. The first step is a reversible step. It involves the conversion of glucose 6-phosphate to glucose 1-phosphate. This basically involves moving the phosphate group to a different location on the glucose molecule. The second step uses uridine. It takes a molecule of uridine triphosphate and reacts it with glucose. This is the same uridine that you may know is used as a monomer in RNA. The enzyme that performs this step is called uridine diphosphate glucose phosphorylase, and it creates a molecule called UDP glucose, which is basically a uridine diphosphate, as I'm circling here, linked to a glucose molecule. The next step uses an enzyme called glycogen synthase. It creates unbranched glycogen. Basically, what this does is it lops off the uridine group and links the glucose molecules together in straight chains with those 1,4 linkages. And then the final step uses an enzyme called the branching enzyme, which creates those 1,6 linkages and creates branched glycogen. When cells in the body want to break down glycogen for fuel, there are several enzymes that can facilitate this process. The first one is called the debranching enzyme, and this can break up the branched glycogen. It can disrupt those 1,6 bonds. We'll talk more about that in a minute. Another enzyme is called glycogen phosphorylase. Glycogen phosphorylase can break up those 1,4 bonds in unbranched glycogen and create molecules of glucose 1-phosphate. Glucose 1-phosphate can be converted to glucose 6-phosphate, and from there, the molecule's fate depends on which tissue is involved. In the muscle cells, there is no glucose 6-phosphatase, so the glucose 6-phosphate can only be used for glycolysis inside of the cell which initially stored the glycogen. In the liver, because of the presence of the enzyme glucose 6-phosphatase, glucose 6-phosphate can be converted to glucose and released into the bloodstream so it can maintain blood sugar levels during times of fasting. Now, there is also an enzyme found inside of lysosomes called alpha-1,4-glucosidase. Lysosomes, as you may know, collect debris inside of cells, and they can collect glycogen. When they collect glycogen, this enzyme will break it down directly into glucose. And the reason this enzyme is important is because, as we will see later, there is one glycogen storage disease where this enzyme is deficient, and that's what results in the symptoms of the condition. Now, let me talk in a little bit more detail about the two enzymes that break down the glycogen polymers. The first enzyme is called glycogen phosphorylase, and as we saw before, this removes glucose molecules from the glycogen polymer and creates molecules of glucose 1-phosphate. If we go back to the previous slide, glycogen phosphorylase is here, breaking down those 1,4 linkages into glucose 1-phosphate. The problem is glycogen phosphorylase stops when glycogen branches decrease to 2 to 4 linked glucose molecules. These are structures called limit dextrins, which I'll show you in a minute. At this point, once it's down to a small molecule of 2 to 4 glucoses and a 1,6 branch, the debranching enzyme has to cleave the limit dextrans so that phosphorylase can keep working. And then another key fact to know is that glycogen phosphorylase is stabilized by vitamin B6. So this is a picture of what the debranching enzyme does. Glycogen phosphorylase can shrink these long chains of 1,4 linkages until they get down to about 3 to 4 units of glucose in size, right near a 1,6 branch. At this point, glycogen phosphorylase cannot work any longer. So the debranching enzyme will pull several glucose molecules from the end and link it to another limit dextran, releasing one molecule of glucose. Once you have a long string like this, the glycogen phosphorylase can begin to work again. And these 3 to 4 unit chains right near a 1,6 branch are what's called the limit dextrans, and these are what the debranching enzyme works on. Now I'm going to talk about the hormonal regulation of glycogen synthesis and breakdown. And the hormones that act on this process have a complicated second messenger system that can be very confusing to remember. I'm going to try to make it very clear for you in a couple of slides so that it sticks in your mind. First of all, you need to recognize that glucagon and epinephrine are elevated in times of fasting or fight or flight, and therefore they favor the breakdown of glycogen into glucose. Insulin, on the other hand, is elevated in the fed state when blood sugar levels are high, and therefore insulin favors the synthesis of glycogen from glucose. So we'll start by talking about glucagon and epinephrine. And the way that glucagon and epinephrine influence the process of glycogen breakdown is through enzyme phosphorylation. Specifically, these two hormones result in the phosphorylation of both glycogen phosphorylase and glycogen synthase. What's confusing is the phosphorylation has opposite effects on the two enzymes. When glycogen phosphorylase becomes phosphorylated, it increases its activity so that it breaks down more glycogen into glucose. This is what glucagon and epinephrine want to have happen. When glycogen synthase, on the other hand, is phosphorylated, its activity falls so that it stops making glycogen. That is also what glucagon and epinephrine want to have happen. So both enzymes are phosphorylated, but it has different effects on their activity level. Insulin, on the other hand, wants to drive this process in the reverse direction. It wants to form glycogen. So as you can imagine, insulin will result in the dephosphorylation of those two enzymes. But just like before, dephosphorylation has opposite effects. Dephosphorylation of glycogen synthase makes it more active so that more glycogen is synthesized. That's what insulin wants to have happen. Dephosphorylation of glycogen phosphorylates lowers its activity so that there is less glycogen breakdown. Here's a depiction of the effects of epinephrine and glucagon on glycogen phosphorylase. Remember that epinephrine and glucagon are always going to result in enzyme phosphorylation, and remember that they want glycogen phosphorylase to be active so that it can break down glycogen. Epinephrine or glucagon bind to their receptors and they activate adenyl cyclase. Adenyl cyclase raises the level of cyclic AMP inside of the cell, and cyclic AMP activates protein kinase A. Protein kinase A then phosphorylates an intermediate called glycogen phosphokinase A, and this enzyme then phosphorylates glycogen phosphorylase so that it can go on to break down glycogen. Here's a depiction of how insulin affects glycogen phosphorylase. The insulin receptor has a tyrosine kinase bound to it. This tyrosine kinase will phosphorylate an enzyme called protein phosphatase 1. The phosphorylated protein phosphatase 1 can remove the phosphate group from GP kinase A, the enzyme I was talking about on the last slide. When the phosphate group is removed, glycogen phosphorylase is not activated, and therefore you have a decrease in glycogen breakdown, which is what you want in the setting of high insulin levels and the fed state. Here's a depiction of the effects of epinephrine and glucagon on glycogen synthase. This is the exact same process that occurred for glycogen phosphorylase. The difference here is that the phosphorylated enzyme cannot do its job, and therefore you get inhibition of glycogen synthesis in this case. And then finally, here's a depiction of insulin's effects on glycogen synthase. It's the same process we saw before for phosphorylase. This results in a dephosphorylated enzyme, glycogen synthase, and the dephosphorylated enzyme is more functional, and therefore it carries out glycogen synthesis for insulin. Now, you should be aware that inside muscles, there is a way to activate glycogen phosphorylase in the absence of hormones. When you begin exercising, you want glycogen breakdown to occur immediately. You don't want to have to wait for hormone levels to become elevated. So the calcium and calmodulin complex that is generated by active muscles can directly activate GP kinase A, which will phosphorylate glycogen phosphorylase and lead to glycogen breakdown. It's the calcium that triggers this process, and in this way, muscles don't have to wait for hormone levels to tell them to start breaking down glycogen. Hormones aren't the only things that can influence glycogen synthesis and breakdown. There are molecules inside of the cell that can influence the process. When AMP levels are high, this means that the cell is breaking down lots of ATP and it needs more energy. So this will activate the breakdown of glycogen into glucose so the cell can use the glucose to generate more ATP. When the levels of glucose 6 phosphate are high, this means that the cell has lots of glycolysis intermediates. Glucose 6 phosphate is an intermediate of glycolysis, and this will favor the conversion of glucose into glycogen so that the cell begins to store some of those carbon molecules as glycogen. When levels of ATP and glucose are high, it means that the cell has lots of energy around, and this will inhibit glycogen phosphorylase so that glycogen stops getting broken down into glucose and ATP. In another module, we'll talk about how the body reacts to times of fasting, but I just want to mention how long glycogen can last as fuel. So this is a slide that you can find in many pharmacology textbooks, and it shows the glucose grams per hour inside of the body and the sources of those grams per hour during fasting. So in less than 8 hours, you will use up all the glucose that you ingested in your final meal before you began fasting. At that point in time, the use of glycogen for fuel will begin to increase, but the glycogen inside your body can only last about a day or so. After about 24 to 36 hours, all the glycogen is gone. Beyond that point in time, any glucose you find in the bloodstream will come from gluconeogenesis and proteins and fatty acids. And this is a picture of Gandhi here. If you know the history of India, you know that Gandhi used to go on these hunger strikes. And so I always think of him not having eaten for 30 or 60 days. And I think that all of his glucose is coming from his protein and fatty acids. And that's probably why he's so skinny. I'll finish this module by talking about the glycogen storage disease. These are very rare inborn errors of metabolism. Most of these are autosomal recessive disorders, and children are born with a defective ability to break down glycogen. The symptoms depend specifically on which enzyme is defective, but in the liver, if you can't break down glycogen, you can develop hypoglycemia, because recall that the liver maintains your glucose levels in times of fasting from glycogen breakdown. In the muscles, if you can't break down glycogen, you can get weakness. And there are more than 14 glycogen storage diseases that have been described, but there are 4 that they are going to test you on the USMLE Step 1 exam, and that's because these 4 relate to the enzymes involved in breaking down glycogen. If we go back to our overview slide of glycogen breakdown, I showed you that there are 4 enzymes involved. There's the debranching enzyme, glycogen phosphorylase, glucose 6 phosphatase, and the lysosomal enzyme 1,4-glucosidase. And one of these 4 enzymes is going to be deficient in each of the key glycogen storage diseases that you need to know. The first glycogen storage disease is called von Gierk's disease. It's also called glycogen storage disease type 1, and this is a deficiency of the enzyme glucose 6 phosphatase. For most children born with this, the enzyme itself is dysfunctional. That's called type 1A. There's also a rarer type 1B where the enzyme's okay, but the transporter that moves it around the cell is deficient. But in either case, the enzyme doesn't work properly, and that's what leads to the symptoms of the disorder. This generally presents in infancy at about 2 to 6 months of age, and because you lack this enzyme, the liver cannot release glucose into the bloodstream in times of fasting. So these children develop severe hypoglycemia between meals. Between meals, they will get lethargic, they can have hypoglycemic seizures, and they can also develop lactic acidosis from the Cori cycle. We'll talk more about that in a minute. In addition, because they can't get glucose out of the liver, their liver becomes enlarged. There's excess glycogen in the liver. That's why it's called a glycogen storage disease, and this can lead to liver failure in the child. If we go back to our overview slide of glycogen breakdown, this is the enzyme that is dysfunctional, glucose 6 phosphatase. As a result, branched glycogen and unbranched glycogen can be broken down all the way to glucose 6 phosphate, but then the liver cannot convert it into glucose and release it out into the bloodstream. You can imagine that muscles will be okay. They don't have this enzyme and they don't need it. They can use the glucose 6 phosphate inside of their muscle cells for glycolysis. So there aren't usually signs of muscle weakness. The major problem is that the liver cannot get the glucose out into the bloodstream in times of fasting. The reason children with von Gierk's disease develop a lactic acidosis is because the Cori cycle, which is also called the lactate cycle, becomes dysfunctional. Muscle cells and red blood cells can produce lactate, which is released into the bloodstream and travels back to the liver. The liver can then convert it into glucose and release it back into the bloodstream so that muscle cells and red cells can use the glucose for energy. In children with von Gierk's disease, this process is disrupted. The final step inside of liver cells of the Cori cycle is to convert glucose 6 phosphate into glucose using glucose 6 phosphatase, the enzyme that is dysfunctional in von Gierk's disease. As a result, the Cori cycle breaks down and the lactic acid level rises in the bloodstream, and that's why children with this condition develop a lactic acidosis. Historically, the way to diagnose von Gierk's disease was to perform a liver biopsy on the child and show increased stores of glycogen inside of hepatocytes. This is an invasive test, and in the modern era, it's been replaced by DNA testing, which is non-invasive and therefore is preferred. You can treat these children by advising them to consume cornstarch between meals. Cornstarch is a glucose polymer, and this will prevent the hypoglycemia that would otherwise develop. These children also need careful dietary counseling because they need to avoid several different substances that can make the condition worse. Specifically, they need to avoid sucrose and lactose and fructose and galactose. All of these molecules feed into the glycolysis pathways, and they cannot be metabolized in the liver to glucose via gluconeogenesis. This means that if the children with von Gehrig's disease consume these substances, they will have worsening accumulation of glucose 6 phosphate. This will be driven into glycogen, and they will get more glycogen stuck in their liver. The next lysosomal storage disease is called Pompe's disease. It's also called glycogen storage disease type 2. This is a deficiency of the enzyme acid alpha glucosidase. It's also called lysosomal acid maltase. Children born with this enzyme deficiency accumulate glycogen in their lysosomes. The classic form presents in infancy, and this is a very severe disease. Children born with this disease often die in infancy or childhood. If we go back to our overview slide of glycogen breakdown, Pompe's disease is caused by a deficiency of the alpha-1,4 glucosidase enzyme inside of lysosomes. This means that glycogen will accumulate inside of lysosomes. Importantly, however, the liver can continue to break down glycogen and even synthesize glucose from glycogen, so you won't see the problems of hypoglycemia between meals that we talked about in von Gehrig's disease. Now, lysosomes are found everywhere in the body, but most of the problems in Pompe's disease come from entrapment of glycogen inside of muscle cells. These children will have enlarged muscles. They can have an enlarged heart and cardiomegaly, and then an enlarged tongue is a classic finding. This is something that's easy to identify on a newborn baby. In addition, their muscles lack tone, so the baby will exhibit hypotonia. The liver can become enlarged, but this is usually from heart failure and engorgement with fluid. It's not from glycogen being trapped inside of the liver. As I said before, there are no metabolic problems in this condition because the liver can still synthesize glucose. And the reason these children usually die is from heart failure. The glycogen gets trapped inside the lysosomes in the heart. This leads to cardiomegaly and heart failure and death. The third type of glycogen storage disease is called Cory's disease. It's also called glycogen storage disease type 3, and this is a deficiency of the debranching enzyme. So back to our overview slide here, the problem in Cory's disease is a deficiency of the debranching enzyme. This means that it is hard for the muscle and the liver to mobilize glycogen into glucose. In many ways, this will be similar to von Gehrig's disease, which was a glucose 6 phosphatase deficiency, except for a couple of important differences. In a debranching enzyme deficiency, gluconeogenesis is still intact. Glucose 6 phosphatase works, and the liver can still synthesize glucose from other carbon sources besides glycogen. This means that the hypoglycemia seen in Cory's disease will not be as severe as in a type 1 glycogen storage disease or von Gehrig's disease. In addition, the debranching enzyme deficiency is going to affect the muscles. Recall that von Gehrig's disease was a deficiency of glucose 6 phosphatase, and this enzyme is only found in the liver. So in a type 1 glycogen storage disease, there are no muscle problems. The muscles are able to normally break down glycogen and use it for glycolysis. This is not the case in a debranching deficiency. In Cory's disease, the muscles, in addition to the liver, both have symptoms. So to summarize, Cory's disease will look similar to type 1 or von Gehrig's disease, except the hypoglycemia will be milder between meals, and that's because gluconeogenesis remains intact. In addition, there will be no lactic acidosis because the Cory cycle also remains intact. The Cory cycle depends on glucose 6 phosphatase, and glucose 6 phosphatase is normal in Cory's disease. And then the other important distinction between von Gehrig's disease and Cory's disease is the muscle involvement. Muscle involvement is part of Cory's disease, and that's because glycogen accumulates in the muscle cells. So the classic presentation to know for your boards is an infant or child with hypoglycemia between meals. This may make you think of von Gehrig's disease, but the hypoglycemia will usually be relatively mild. You usually won't see seizures. The liver will be enlarged, and that also can remind you of von Gehrig's disease, but the distinction will be in the muscles. The muscles will be hypotonic and weak in a baby with Cory's disease. You may even see cardiomyopathy with hypertrophy. The final glycogen storage disease we'll discuss is called McArdle's disease. It's also called glycogen storage disease type 5. This is a deficiency of the enzyme glycogen phosphorylase inside of muscle cells only. This enzyme is sometimes called myophosphorylase. Skeletal muscle has a unique isoform of glycogen phosphorylase, and that's what's deficient in this condition. As a result, glycogen cannot be properly broken down inside of muscle cells. If we go back to our overview slide, this is the enzyme that's deficient in McArdle's disease, and as a result, muscle cells cannot break down the 1,4 bonds inside of glycogen to glucose 1-phosphate molecules. This usually presents in adolescence and early adulthood. It's different from the other glycogen storage disease. There are no liver problems with this condition, so you won't see any issues with hypoglycemia. The problem will be muscle difficulties, exercise intolerance, fatigue, and especially cramps. People with McArdle's disease have poor exercise endurance. Their muscles can swell and be weak. Sometimes these patients develop muscle damage with exercise, and as a result, they can get myoglobin in the urine and creatine kinase release, especially with exercise. And one thing that you may see, especially in a board question, is a patient whose urine turns dark after exercise. That should make you think of muscle damage, and this is one of the reasons that people can have muscle damage with exercise. And that concludes our module on glycogen.